Good morning, everybody. Right, well, we're ready to start and talk about PET in neuroendocrine tumours, which is a fairly significant part of many departments' workload now. But whilst it's a sort of fairly rare tumour, because of our ability to use imaging to determine which patients should have therapy, and we'll discuss that treatment tomorrow morning, we've developed better and better methods of imaging now. If you remember, we talked about SPECT-CT and somatostatin receptor imaging on our first talk on Monday. So this is a sort of follow-up, which is with PET. So, as you know, I normally start with this question: why is gallium like chocolate? And this is evidently a picture of real gallium, not gallium-68, this is stable gallium. And the reason evidently is that gallium, like chocolate, is solid at room temperature and liquid at body temperature. So it's the only element, or at least the only metal element, which does that. So it's just a fun fact, really. So in terms of gallium, it's a group 3 metal, and you can see it sits on top of indium, and actually thallium is also there as well, and aluminium is above it, and it's probably closer in chemical properties to aluminium than it is to thallium. And like indium, it tends to prefer to be what we call trivalent, which is to have a 3+ charge. Now, if you look next to the gallium in the blue box, there's germanium. And germanium for our gallium-68 is our mother isotope, and gallium is therefore the daughter isotope. So whilst germanium has a fairly long half-life, gallium's half-life is very short. It's 68, 69 minutes. So we use a generator system. There are disadvantages in that, in the fact you have to buy a generator, but there are advantages in the fact that you're not dependent on the cyclotron and you can make product locally. So there are some centers around the world who concentrate primarily on gallium type PET because they have poor access to generate cyclotron-based radiopharmaceuticals like F18. So we said is group 4 metal or group 3. It's trivalent, and all these act in the body a bit like iron analogs. So, and you can label it just in the citrate form, as we showed when we looked at the infection lecture. But most of the time, we use it on a peptide or a ligand, which will be PSMA, which we're going to be talking about at lunchtime. And we use a chelator to do that, and that chelator is DOTA. DOTA is a very complex molecule, but what it has is basically 5 nitrogens. So there's 4 nitrogens in a ring, and that holds the gallium-68. And then there's 1 nitrogen which is on a long chain away from that, and that nitrogen enables you to then bind it to various products. Now, it binds very easily to the C terminal of an amino acid, but you can also bind it to other ligands as well. So first of all, let's talk about gallium-67 citrate, which we know is a gamma emitter. It produces multiple gamma rays between 90 to 370 keV, and it has fairly poor dosimetry because of these high energy gammas. And also, the imaging characteristics are fairly poor because these high gammas produce a lot of scatter. But it was found useful for inflammation and infection. And this is a patient with sarcoid with uptake of gallium seen in the lacrimal glands, nasal mucosa, parotids, lungs, liver, and lymph nodes in the inguinal region. Now, obviously, Gallium-68 has another neutron. That's why its atomic weight goes up. And unlike 67, it is a positron emitter. Now, the other thing is that gallium-67 is quite, again, you need to make it in a cyclotron, and it has a fairly long half-life of about 3 days, whereas we know that gallium-68 half-life is very short. So these generators have a 127-day half-life, the gallium-germanium generators. Still primarily the two sites of production are Russia and South America. They may get repackaged in other countries. So you may say they're made in Belgium or made in Germany, but the actual core of the generator comes from either Russia or South Africa. When you first dilute it, you can get up to 500 megabecquerels, not gigabecquerels. And the germanium breakthrough rate is fairly low, less than 0.02%. You don't want germanium because it's got a long half-life. It takes about 12 minutes to elute it, and you can probably do 2 and possibly 3 elutions in a day. One of the problems with a shorter half-life is you want to use fairly rapid chemistry. So they tend to use sort of automated machines for this. So this is what we can buy in Europe, which is one of the 2 generators we get. This is the AIFNOTA one. This is made in South Africa. I would say it's not made in routine production. It is in pretty routine production now. Getting hold of these generators is easier than it was. We had a period in 2018 and 2019 where it was difficult to obtain these generators, but they seem to have sort of sorted out quite a lot of the production issues. So this is a photograph of one of the advertising sheets from, this is actually from a company in the Netherlands that will sell you your South African generator for you. But you still need to get a linker molecule. So either there's 2 ones that are used primarily, DOTATATE, which is, to be honest, is the preferred one and is available in most countries. But for some very bizarre reason that nobody knows to do with patents, we have to use DOTANOC, which is not quite as good, but is based on ordinary octreotide and not octreotate within Europe. Again, you can manufacture the whole thing using a kit-based issue, but radiopharmacists aren't very keen on that because obviously you have a positron emitter, and handling that kind of product is pretty difficult because of the dose that you get to your fingers. There are a couple of things that can be done. We can put lead bricks in front and try and use long-handled tongs, which is what a lot of places do, but it obviously makes the manipulation of these vials very difficult. The better solution, if you can, is to buy one of these modular laboratories, and these just automatically produce the gallium DOTATATE or DOTANOC. And also you can put different reagents in and they'll make gallium PSMA for you. So where I was in Cambridge, they preferred to use the manual system. But where we are in London, all the hospitals have got together and we bought 2 or 3 of these big units, and they're put into centralized hospital pharmacies. And different days, different hospitals get their gallium, but because they got several of these manufacturing labs now, you can get quite significant amounts. So, for example, at Barts, where I work, we get gallium 2 days a week, but we get enough doses for 8 patients on each day. So it's been turned into a bit of a sort of commercial organization, which is good. So gallium-68 had been used in research for 40 years and really hadn't gone anywhere. People had tried it with various different radiopharmaceuticals. You could even get gallium DTPA to do PET renograms, but it was never really that popular. So it really came to the group in Heidelberg who really started to think about how we could use this. And what they did is they got hold of some DOTATATE from the University of Basel, and they were able to get gallium-68 to stick to it. And the timing was just perfect because PET-CTs were starting to be delivered around Europe in 2001. So increasing number of centers, particularly in Germany and the Netherlands and France, were getting PET-CT scanners. And obviously when you add PET-CT to a PET tracer, you have a very powerful diagnostic tool. So we have the advantage of the gallium-68, we have the DOTA, and we have the TATE, which is this alcoholized somatostatin analog. And so we now have to use the TOC, which is not quite as good in parts of Europe, but I think here in South Africa, you still use the TATE, which is the better of the two. So the first sort of papers came out in good series comparing the gallium-68 DOTATATE and the old-fashioned indium octreotide. This is made from the JNM from Innsbruck. And they demonstrated that the sensitivity, the ability to find tumor was very much better. And that was better for two reasons. One, they were using the DOTATATE, and secondly, with the PET system, you were able to see much smaller tumor sites. So this is some work that was done just as I was leaving the Royal Free in 2010. And here they were comparing pentetratide and gallium-68 DOTATATE in patients with neuroendocrine tumors, looking at the difference between the two. And they had 44 patients, and in both studies, the gallium-68 were positive in 18 patients, but there were more lesions seen with the gallium-68 DOTATATE. There was one patient which, interestingly, had more lesions seen with the indium octreotide, but that's quite rare. Both studies having similar lesions, only 7 patients, it wasn't a big number. And then there was the big, really important number, which was the number of patients where the indium 111 was negative, but the gallium-68 DOTATATE was positive. And there were 11 of those patients. There were no patients in which the indium was negative, so the gallium was negative and indium positive. And there were 7 patients that still were negative, and these probably had tumors that didn't have receptors on them. So these are some images from that study. Now these are images that are from actual, they're not taken from the paper, they're actually patients that were my patients that were in the study, if you know what I mean. So we have, if you can look at the black and white image, we have a patient who has a sort of dot in the lower abdomen. That's a bit of urinary activity, but further up we can see there's some low-grade uptake here. And we thought this was a mesenteric node. And indeed, you can see that much more clearly on the PET-CT. Now, the important thing is that when you look in the liver, you just can't see any tumor at all. But with the gallium-68 PET-CT, the DOTATATE, you can see multiple liver lesions. So if you wanted this patient to be considered for PRRT, and if you relied on the octreotide scan, you'd say, no, this patient shouldn't have treatment. But when you go to the PET scan, you can say, actually, yes, this patient should have treatment. And this is another one where this is just a MIP image versus the whole body. And you can see again, there are 2 lesions in the chest and there's one in the liver, which you can clearly see on the gallium-68 DOTATATE PET, and they're just not there on the indium octreotide. Sometimes the indium is positive in this study, and that was, if you remember, 18 patients out of 44. And you can see here, probably on the indium octreotide, these 2 slices, you've got 2, possibly 3 liver lesions. This one's a little bit more difficult to see, but there's 1, 2, possibly 3. But when you look on the gallium-68 DOTATATE PET, you can actually see there are multiple liver lesions. So just using the indium octreotide, you might be tempted to think, well, we could surgically operate on this patient. But when you look at the gallium-68 DOTATATE PET, you realize that that's really not possible at all. You can pick up fairly small sites of tumor. So this is a patient who was actually a South African who had moved to the UK, a patient who was a dentist. We won't hold that against them, but they were a dentist, and they had presented with abdominal pain, and a CT scan had showed a large mesenteric node. And we knew the patient had a mesenteric node. This had been biopsied under CT and was found to be a neuroendocrine tumor. But we wanted to know if the patient, there are any other sites of disease. So we did this gallium-68 DOTATATE, and you can see this is the mesenteric node on the CT scan, and it is indeed positive here on the DOTATATE PET. But what we couldn't see on the CT scan is this little dot here, which you can see here on the fused image, and that's the primary tumor. So we were able to guide the surgeon to remove the primary and the nodal tumor, and this effectively cured the patient, and the patient has not had any recurrent disease. And this operation was done in 2011, so they've had 10 years disease-free. So that's the power of the gallium-68 DOTATATE, is we don't just use it for patients with metastatic disease, but because we know that we can pick up almost all the known tumor, we can use it to stage patients. So what about pancreatic tumors? Because they are a little bit different, if you remember, in the fact that sometimes they're not positive on indium octreotide. And one of the reasons is that pancreatic tumors, particularly things like insulinomas, can be very, very small. They can be 4 or 5 millimeters, but still cause significant endocrine symptoms. So PET has an advantage there. The only thing you do have to be aware of is that there is sometimes diffuse increased gallium-68 DOTATATE uptake in particularly the pancreatic head. So be careful that you get used to the normal distribution of gallium-68 DOTATATE in the pancreas. Traditionally, we would do F18 FDG in these pancreatic neuroendocrine tumors, but that's because indium octreotide really wasn't working. But once we started to get the gallium-68 DOTATATE PET, we found that they were often both positive. So in the midgut neuroendocrine tumors, the classical carcinoids, if the FDG is positive, the DOTATATE tends to be negative. But in pancreatics, they can be both positive. But we did find more false positives with F18, particularly inflammation. So for staging, we recommend using the DOTATATE. Other tumors, of course, can be used, and this includes other neuroendocrine tumors such as medullary thyroid cancer. And this was a paper published in 2010 looking at 18 patients. And here they found that the DOTATATE wasn't quite as good as the FDG. And the reason being is probably because some of these medullary thyroid cancers don't have the somatostatin 2 receptor. And this is where DOTA-NOC, which also attaches to the somatostatin 5 receptor, may be an advantage, though personally I've not seen that in reality, but theoretically they might be an advantage. So for medullary cell carcinoma of the thyroid, even though it is a neuroendocrine tumor, we still recommend having FDG as your first method of imaging. So there was a multi-center trial that was published in the JNM in 2016 of 78 patients imaged with NET. So this was with blinded reads. So the scans were done in hospitals across the United States. And then the scans were sent to a set of readers who didn't know anything about the patients, and they had to read them. And then those results were compared with the actual pathological an imaging-based knowledge of where the disease was. And you can see overall the sensitivity of indium octreotide was 73% and specificity was 93%, whilst with gallium-68 DOTATATE, the sensitivity was 96% and specificity 93%. So you can see why we've begun to rely much more on the gallium-68 DOTATATE PET-CT. And many centres that used to not know which one to do now just use the DOTATATE or DOTANOC PET. They also went back to the original hospitals and said, how did the imaging change management? And they said that in 28 out of 78 patients, management was changed. And unfortunately, most of the time, surgical treatment was cancelled because they realized the patient had metastatic disease. But it would be, though it may be considered, unfortunately, you find a disease, it's better the patients don't have unnecessary operations. And of course, we do have the option now of PRRT. So when we started off with indium octreotide, we always used to think that if one was, FTG was positive, gallium-68 DOTATATE would be negative. But we said it is, it's not actually as clear as that, as in some patients seem to have positivity in both, particularly in the pancreatic origin ones. And also, there seems to be a genetic base that if you've got the genetics that enable you to get a neuroendocrine tumor, you are more likely to get an adenocarcinoma. So if you can see something on a CT scan and it doesn't light up with DOTATATE, but other sites do, it could be a dedifferentiated neuroendocrine tumor, but it could also be a second cancer. So we do recommend that these patients have a FTG scan. So this was the traditional idea, is that as you would get more uptake of somatostatin, then they were more benign, and more uptake of FTG, they're more malignant. And there's still some trueness in that, but there's a lot of patients who sit in the middle, and they may not particularly have malignant disease. And this is, there's a group of patients who have multiple endocrine neoplasia type 1, who can be quite positive with both, but have quite indolent disease. So this is a cautionary tale. Now, this patient was a professor of pathology. So that's explained why we did what we did. So this patient presented to her emergency department or her hospital because she felt a node up in the left supraclavicular fossa, and she knew that was likely to be a Burkhoff's node, and she thought she probably had a gastrointestinal cancer because she's a pathologist and that's where she knows about these things. And that was biopsied and found to be a neuroendocrine tumor, but with a high Ki-67, and Ki-67 is a marker of how quickly the cells are dividing. So she was referred to us, and we, because of the high Ki-67, we agreed to do an FTG PET and a gallium-68 DOTATATE PET. And you can see here a sagittal slice of both tracers, and they're through the same part of the body. And with FTG, we saw a lot of nodes in the mediastinum and abdomen. And with the gallium-68 DOTATATE, we saw a single node in the abdomen. Now, because she was a professor of pathology, she said, well, I need tissue from both. I've got the FTG avid lesion. Can you get me the DOTATATE lesion? So she had that done under a CT-directed biopsy. And that came back as looking the same neuroendocrine tumor under the microscope, but the Ki-67 was only 1%. So this patient had two types of neuroendocrine tumor. Now, the point is this one isn't going to kill the patient. It might take a decade to be a problem, but this one can kill the patient. So the patient went on, to have chemotherapy and responded very well. This is another patient who had a midgut neuroendocrine tumor, And you can see here that there are multiple nodes here in the abdomen, and there's multiple liver metastases. A very classical midgut carcinoid type tumor. But when they did the CT part, they noticed that there was this lung nodule. And this lung nodule didn't have uptake of the gallium-68 DOTATATE. So they wondered if this could be something else. So they arranged for an FDG PET study. And you can see very nicely that the neuroendocrine tumor is negative on the FDG PET, but that lung lesion is quite positive. You can see here quite intense uptake. And this did indeed prove to be a T2 N0 M0 lung carcinoma, which was subsequently removed surgically. So if you see unexpected sites of disease that you don't get uptake of DOTATATE, do consider doing an FDG PET study. How do things compare with other imaging like CT-MR? To be honest, there's very little data on this. There was a paper published from Munich in 2013 with 18 patients with pancreatic neuroendocrine tumor. And as expected, the MR wasn't as good as the gallium-68 DOTATATE PET. And in our practice, we really don't do CT or MR in these patients because we don't find this very useful. They may have a CT-MR initially, that is how it's diagnosed, but once the diagnosis has been made, we tend to follow them up using CT and using the DOTATATE PET as the primary method of follow-up. So just some more examples. This is an indium octreotide study in a patient with no metastatic neuroendocrine tumor. So you can clearly see that there's no uptake in the tumor itself, no uptake in the liver. You can't see anything. But here is the DOTATATE PET CT, and you can see that there is disease in the lung, and there's disease throughout the liver. And there's also, if you look very carefully, there's a bone metastasis in the pelvis. So we would expect most small bowel neuroendocrine tumors to have uptake of indium octreotide, but this patient clearly doesn't. But this patient should still be offered PRRT. And this is the same patient having had their PRRT, and you can see very good uptake in the sites of tumor. Unfortunately, there was a bit of a delay, so they got more bone mets whilst we were waiting for approval for treatment from the insurance company. But it did show that there was a good change and good uptake within the tumor itself. So the gallium-68 DOTATATE was a much better predictor of tumor uptake than was the indium octreotide. So again, if you're heading towards PRRT, we would recommend patients are imaged with the gallium PET agent. And I'm going to talk about the therapy in the next talk. Not next talk, at the end of the day, because we've got PSMA next talk. No, therapy, sorry, I'm confusing myself, is tomorrow morning with PRRT. But one of the main uses in our practice is to determine those patients who should go forward for PRRT, because the uptake of the therapeutic agent matches the PET distribution much more than the non-PET distribution. What we don't really know is how to monitor response, because we don't know if you stop having uptake of the DOTATATE, is the tumor dead or has it just lost its receptors? So we're still stuck with CT as follow-up. And this is a nice example. This is an ACTH-Homa. I was talking about them yesterday and saying they're often negative. This was a positive one. And in fact, is that same patient as we showed you with the Burkhoff's node. This patient had a gallium-68 DOTATATE. In fact, they had a PET MR because they were fairly young, and we had the option of doing that. And you can see uptake in the liver. And then this is the same patient's lutetium DOTATATE showing successful uptake in the tumor. And this patient did very well in terms of getting rid of their Cushing syndrome. They responded extremely well. There are some other PET tracers that have been tried. DOPA and DOPAmine looks at amine uptake in nets and is particularly useful in paraganglioma and pheochromocytoma. Some people have, particularly in Sweden, have tried 5-hydroxytryptophan, labeled with C11. And again, obviously, we can use the C11 methionine as well. But these are really more for specialist areas. So this is an image that was published in the paper, an endocrine journal paper, and it shows this is a patient with a malignant pheochromocytoma, so it's not a carcinoid. And there's an MRBG study that shows uptake here in the liver. There's an FDG PET that shows some malignant nodes and malignant uptake in the liver. Then this is a DOPA PET, and this shows uptake in liver, but it doesn't, and in the shoulder, but it doesn't show the uptake in the nodes in the neck. And then this is a dopamine, fluorinated dopamine scan, and this shows uptake in the shoulder, some uptake in the liver, but not the same as in the DOPA. And then it shows bone mets in the legs, which you don't really see with the other agents. And what the lesson of this is that some of these tumors can be quite difficult to work out what's happening, and you may need to do multiple agents. Really, we don't use these agents clinically because, as I explained before, DOPA and DOPAmine are very expensive for us. In fact, we can't get fluorinated dopamine in the UK. But what they didn't do in this patient, which would have been interesting, would have been the Ga-68 DOTATATE, and I think it's because it was published before that became widely available. So there are some new ideas. One of them is to use an antagonist instead of agonist, which then can improve the selectivity. And the idea being is that antagonists might be better at sticking onto the cell because they are directed against a receptor and they don't get internalized. Also, gallium-68, because of its short half-life, is not popular in the United States of America. It can take you 2 hours to drive across one city in the United States. So people have looked at fluorinated products, but at the moment, the one that's been very successful is the copper-64 based product. And there was some papers published in 2018 on this, and subsequently in 2020, this copper-64 agent became a licensed product. So this is some work that was done a couple of years back, looking at antagonists, and this one is called J11. And the one thing you can see about the antagonists is, and that's in panel A and B, compared to DOTATATE, which is C and D, is you have less physiological uptake. So you can see smaller liver lesions much more easily. And they're showing here how it compares much better with the MR. And of course, you can do a theragnostic version of this as well, which might reduce some of the systemic side effects that you get with the lutetium DOTATATE. So I think this is a very interesting area. It's still fairly new, but it may be a way forwards in producing a sort of a super quality somatostatin scan and hopefully treatment as well. So this copper DOTATATE has a name in America called DETECT-NET. And to be honest, it is pretty similar in terms of distribution to the gallium, but it has a couple of small advantages. It has less normal liver activity and it has less gut activity than the gallium. So in the abdomen, you do get a cleaner issue, a cleaner image. The T-half is about 12 hours. So you can imagine that it might be possible in a country such as we have in the UK or in South Africa to have a single site manufacturing and then distribute by plane or by even van within one province. So this could be something which could take over from the gallium in the future. However, the radiation dose of the patient is much higher because of the longer half-life. That's not an issue in America, but it may be an issue in other countries. So these are all areas where people are sort of trying to improve on the gallium product. Fluorinated PETs also heading our way, and again, companies are looking at this. And that's the interesting thing is, whilst beforehand it was all done by universities and hospitals trying to develop their own products, now these things are now being developed by companies. And this is one called AIF-NOTA octreotide. So it's basically still an octreotide, and this is another interesting patient where you can see different lesions between FDG PET, which is the panels on the right, and the fluorinated NOTA octreotide, the panels on the left. And this is, again, showing that you sometimes need to image with both. So if you had just done the fluorinated NOTA octreotide, you might say, oh, I'll treat that patient with PRRT, but in fact, if you'd done the FDG PET in this patient, you would have seen there was quite a big liver lesion that you would have not treated. And this patient may need a combination of chemotherapy and then PRRT. So in conclusion, gallium-68 products combine the improved sensitivity, and with the improved spatial resolution of PET, you basically find about 30% more tumors than indium octreotide. There is an increasing range of radiopharmaceuticals, which may suit different types of where you are, what you can get hold of. Do you have a chemist that can use a generator? If not, then hopefully soon there's fluorinated and copper-based products that will become more widely available. And these all have a key role in diagnostics because you want to see the best chance of seeing the tumor, because that gives you the best prediction of response. So I will now oh, sorry, not that there. I'm just trying to turn the that's it. It's very annoying.